Good evening, everybody. I'm Chrissi Kelly of AbScent. Welcome to this evening's webinar. My guest this evening is Professor Claire Hopkins, and Claire is going to be talking to us about the latest developments in olfactory loss. So it's a great pleasure to have you with us, Claire. Thank you very much for joining us.
Pleasure. Thank you very much for having me.
Good. Before we begin, I would just like to say that the usual rules apply. If you have a question that you would like to put to Professor Hopkins, please go down to our Q&A channel there and put your question in. If you've got any other problems then you'd like to, not questions for Professor Hopkins, but any other comments you need to make, you can put them there. So I hope to be taking your questions this evening. Let's just open that up. And so, Claire, let's get started. I think a lot's going on for you right now. There's been a lot of news. We've learned rather a lot more about COVID-related smell loss and other kinds of smell loss since we last spoke. So why don't I turn it over to you? And I think you might talk to us a little bit about something new in the area of polyps and how that might relate to COVID. So I'll let you take over now.
So before the COVID pandemic, and that seems a lifetime ago for all of us, I'm sure, my main area of research interest was looking at nasal polyps and smell loss associated with that. And loss of sense of smell is the most important symptom for patients with nasal polyps, and it's found in about 95% of people with polyps. So it's a big feature of that. And in the past, we always believed that the loss of sense of smell for people with nasal polyps was simply because the polyps obstructed the nose and stopped odorants reaching up to the olfactory cleft. And so the thought was, if you could remove the polyps, get the odorants back up there, sense of smell would be restored. But actually, when you look at the effectiveness of treatments such as surgery for nasal polyps, we find that although 1 in 4 patients get their sense of smell back, in 3 out of 4, the improvement isn't as good as we would like, and there's only partial improvement or no improvement, even though the physical bulk of the polyps has gone. And so we started to understand that the inflammation going on in polyps was actually just as important as the physical obstruction. Now, there have been huge advances in the treatment of nasal polyps, particularly those with the most severe disease, in that we've now identified the inflammatory cells involved in the formation of polyps, cells called eosinophils predominantly, and the inflammatory chemicals that activate all of what we call type 2 inflammation. And whereas in the past we've relied on prednisolone, which is very effective in restoring people's sense of smell, and I'll have many patients that save their burst of steroids for Christmas or anniversaries because they'll know that they'll get a good few meals back. The problem with prednisolone is that the benefit's often quite short-lived, and usually certainly within 3 months, but often within weeks, people are back to where they started. And the problem is you can't keep using doses of steroids because of the side effects. Oral steroids are essentially a little bit like napalm for the immune system. They take out all of the immune system, the good and the bad. But having identified the cells involved in forming polyps and the chemicals involved in activating those cells, we can now use much more targeted drugs called monoclonal antibodies that specifically block the chemicals or the cells that we don't want to be active while leaving the rest of the immune system alone. And so we now have a number of monoclonal antibodies that are approved for use in patients with nasal polyps: dupilumab, omalizumab, and mepolizumab, and there are others going through trials at the moment.
And Claire, could I just ask you, these drugs, are they widely available on the NHS for people with polyps?
So that's the problem. In the UK at the moment, although they're approved for use in the European Medicines Agency and we can prescribe them, the cost of the drug at the moment isn't approved for prescribing within the NHS.
Right.
So at least in the UK, drugs have to go through a process of evaluation by NICE, and the National Institute of Clinical Excellence, and they decide whether new drugs can be made available in the NHS for patients. Mm-hmm. Now, these drugs are available for patients with severe uncontrolled asthma. So if patients, many of whom have nasal polyps, also have asthma as well, if they have uncontrolled asthma needing regular courses of oral steroids, then they may well be able to go on a biologic in the NHS for their asthma, and that will have the benefit of treating their polyps as well.
Right, right.
at the moment for nasal polyps and loss of sense of smell, the drugs don't meet the threshold for NICE to approve based on what they call their cost effectiveness. That's a measure of the cost of the drug, but also the amount of benefit it has on what NICE measures as quality of life. But the problem is that the metrics that NICE use are whether you can climb the stairs, get yourself dressed, go to work, and whether you have pain. And it doesn't include loss of sense of smell in that equation. And so at the moment, they're not available in the NHS. They're widely available in Europe and in the US and many other countries, but we're certainly in the UK lagging behind in that area.
Right. I was in Austria on the weekend, and I met a doctor who is familiar with the problem, who said that it is widely available there for polyps on their sort of with their health service. So
yeah,
well,
I mean,
maybe
it's
fingers
really
crossed.
frustrating for people in the UK because you know you can see on social media, read reports of people having these drugs, and they really do describe them as a game changer. And you know, I am able to prescribe to a very small number of people that are fortunate enough to be able to pay for them themselves, but they are very expensive.
Yeah.
And what you often see, within 3 or 4 days of giving the first injection, I'll get an email from a patient going, you know, it's absolutely amazing. For the first time, I've smelt my perfume in 10 years. I've opened a great bottle of wine. And suddenly, you know, their sense of smell, which they won't have had often for 10, 20 years, restored.
Wonderful.
That's really important because that tells us several things. You know, these are people that haven't been able to smell for many years, but we're able to get it back. So that tells us that even though we're not stimulating the olfactory cortex, that there's no signal getting through, the mechanism is there, and there is potential to restore things. So that's really important. You know, I think everyone will have seen the reports in the papers a few weeks ago about patients with COVID losing some of their brain volume, and that sounds hugely dramatic, but the way I would describe that is if you had broken your arm and you had your arm in a plaster cast, when the cast comes off, the muscles, because they haven't been used, are all withered and shrunken down because they've not been stimulated. And that's exactly the same for the olfactory cortex, the area of the brain where we smell. Because there aren't signals coming through, it's not being stimulated, and it shrinks down from lack of use. But just like after you have your cast removed, you have your physiotherapy to exercise the muscle and build it back up again. When the signals come back and we can stimulate that area will recover, swell back to its normal size. So it's not brain loss, it's you know, the brain's very plastic, so it's making and losing connections all the time. And that area, for lack of stimulation, has shrunk down, but has every chance to recover when smell recovers. And that's probably where smell training comes in. It's a little bit like physiotherapy for that area that hasn't been stimulated. But that data that we see in patients receiving a biologic tells me that even if that area hasn't been stimulated for 10 years, there's potential for it to recover and come back to work very well. So that gives great hope for people with long-term loss from any cause, that if we have a better understanding of the mechanism, we can treat it, and there's potential for everything to recover.
Right. So thank you for that. We had somebody ask what injections are we talking about? So just to review, we've been talking about biologics, which are a kind of drug that can help people who have polyps. But Claire, what we started to talk about, and which you mentioned before we went on air, is that you know a little bit more about the mechanism that creates the inflammation that is the problem with polyps. So what's the exciting bit about that new information?
Well, it's coming back to learning how quickly people respond to these drugs. So it takes several months for the polyps to shrink down in size for a patient on these monoclonal antibodies. But we're seeing patients get their sense of smell back often within days of their first injection. So we now understand much better it's not simply obstruction of the nasal cavity that causes the smell loss in people with polyps, but it's likely to be something in the underlying epithelium, the inflammation itself, that's causing blockage. Now, there's a group at Hopkins University in the States, no relation, led by Andy Lane, and they've been doing lots of work looking at the underlying mechanism of smell loss in patients with polyps. And what's really interesting is that they found that the stem cells that we all know naturally replenish the olfactory neurons on a regular basis. When you have polyps, instead of creating new olfactory neurons, they're diverted to creating inflammatory cells to try and tackle the inflammation going on in the nasal polyps. So they're so wrapped up in dealing with the inflammation, the stem cells can't do what they're supposed to do, and that is replace the olfactory nerves. There's also been evidence that the receptors on the ends of the nerves that are there are also down-regulated by inflammation.
And so what does that mean? What does that mean when a receptor is down-regulated?
So if you imagine an olfactory nerve might have 20 receptors sitting on the end of it waiting for odorants to come in. And when the odorants come in, they bind and send a signal. Now, as the odorants come in, once all of those receptors are taken up, you can't detect the smell anymore. So if you don't have many receptors, you'll get that first hit of smell when you take a mouthful of food, but then it won't be maintained throughout the meal because the receptors that you have are saturated very quickly. Now, what happens over time is those receptor packages get taken in, the odorant gets released and they get recycled. But if you are, even if you have the right number of olfactory nerves, if you have a small number of receptors, you won't get sustained taste and smell. It will be saturated. You'll get a quick hit and then it will go, or you'll simply not detect it at a very high level. And what's really interesting is that there is growing evidence of a crossover in this mechanism. There's things that we're seeing in nasal polyps also in people with post-COVID smell loss.
Right.
We know that for the majority of COVID smell loss is split into two main groups. A group of people that recover very quickly. You know, there's no injury to the nerves themselves. They lose their sense of smell and taste for 5 to 10 days, and then they're back to normal and they forget all about it. And, you know, we won't be likely seeing any of those people listening into the webinar because they will almost have forgotten about it. But for everyone else, there's a loss of the olfactory sensory nerves, and it takes time for those to recover. Now, the remarkable thing about the olfactory system is that they can recover, and the stem cells are there ready to regrow these nerves, but it's quite a complex process. The stem cells have to create olfactory sensory neurons and not inflammatory cells. The olfactory sensory neurons have to make the right connections, and we think that cross-wiring may lead to Porosmia. And then they have to express the right number of receptors on the end. And just as we found in patients with inflammatory conditions such as nasal polyps, there seems to be problems at all of those stages in COVID, in post-COVID anosmia. There seems to be a level of ongoing inflammation within the olfactory epithelium. And that's likely suppressing the reactivation of the stem cells. So that initial recovery phase where the stem cells repopulate into olfactory nerves isn't working as well as it should. So that delays recovery. There aren't enough nerves coming through, therefore recovery is suboptimal. So we see many people with some recovery, but what we call hyposmia, a reduced strength of smell. That can get cross-wiring, so we see many people with Porosmia. But there's also evidence now in post-COVID anosmia that we get this down-regulation of receptor expression as well. And that could fluctuate on a day-to-day basis. So that might explain some of the fluctuations that we see in post-COVID anosmia. Because if you've got a change in the number of receptors, you'll have good days and bad days. And that might be linked to levels of inflammation within the olfactory epithelium.
Right.
So there is this crossover with our understanding in how we might be able to treat the inflammation to try and get better outcomes in both groups of patients.
So do you think that, you know, what we know about treating polyps, you know, I mean, obviously we can't use biologics on everyone. That's just not an option. But might there be other avenues that open up now that we understand a little bit more about this inflammatory process?
Well, I think absolutely. So first of all, maybe we could use a biologic, and that's certainly something that could be explored. The problem with biologics is they need to be given by injection. They are hugely expensive, but it also opens up the possibility of using a whole range of other anti-inflammatory drugs. So, for example, we have seen in post-viral loss before, steroid irrigations into the nose are effective in the treatment of post-viral loss. Irrigations get the steroids up to the olfactory epithelium, and so you can actually deliver an anti-inflammatory to where you want it. We've heard of lots of interest in PRP injections, and that has both a stimulatory effect on the stem cells, but also an anti-inflammatory action. And there are a number of groups that have been researching this. Group in Stanford looking at injections. There's another group in Jefferson looking at PRP gels. And there's a group from France and Belgium that have just published some preliminary results from a randomized controlled trial using PRP injections. And they have shown benefit in the group that had PRP compared to a controlled group that didn't have treatments. So we're starting to see some evidence that that is likely a potential option of treatment.
And do you think that PRP is only useful for people who have had fresh loss? Or do you think that 9 months down the line or a year down the line that it still might be a useful intervention?
So again, that's something that we're going to have to evaluate in studies. But what we see in biopsies is generally the stem cells are still there. They're not depleted. And as I said, that reassuring information from studies in polyps where you can restore the sense of smell after 10 years tells me that I think there is still very likely to be benefit for people coming up to now 2 years of loss post-COVID. You know, we haven't seen evidence that that recovery tails off. And, you know, I see loads of reports on Facebook, really awful stories of people that have been to see an ENT surgeon or a family doctor, and they've been told, oh, now you're at 12 months, that this is permanent, or now you're at 18 months, this is permanent. And that's simply not true. We've known for post-viral loss before COVID that there is still a chance of recovery many years down the line. And that's what we've said all along in sort of these forums and tried to reassure people. And that's very much what we're seeing. We're still seeing reports of people 18 months after COVID, 24 months after COVID, reporting spontaneous recovery. So we know that potential is still there.
There was a recent post in on one of our forums, someone who is 2 years, 2 months in and is now experiencing recovery.
Yeah. And I'm sure that that will continue. So I honestly think the stem cells are still there. They have the potential to be stimulated to recover. The receptors, we need to find ways to treat the inflammation to allow this process to happen well. But I really would encourage people not to give up hope, whatever stage that they're at. And there is so much research going on all around the world looking at different anti-inflammatories. For example, omega-3 is still being studied. There is a small but positive result from a study using something called palmitoyl ethanolamide and luteolin. Now, palmitoyl ethanolamide is a natural fatty acid. It's a little bit like alpha-lipoic acid or omega-3. And it's said to be neuroprotective and stimulate nerve recovery, but it's also an anti-inflammatory. So again, that's been shown in a small trial with a control arm to achieve better outcomes than the control. We need more data to look at that, but this is a supplement that's available over the counter that again is likely acting on that inflammation. So I think that really needs to be our current focus. How do we better reduce inflammation that's at a subepithelial level, something you can't see, but you can measure within a tissue biopsy for research purposes?
Let me ask you a question that I've always wondered about. I mean, we hear a lot about, anti-inflammatories. What about non-steroidal anti-inflammatories? Are they of any use whatsoever?
Well, they're a little bit more complicated because they also have side effects such as gastric irritation. To be honest, I haven't seen them studied in any way at all. One of the things that's quite interesting at the moment is using antihistamines, and that's certainly been looked at in other areas of long COVID. And certainly there is some evidence emerging that long COVID in general is related in part to what we call a mast cell activation syndrome. Mast cells are part of the immune response that make histamine, and they seem to be overly sort of active after COVID and keep releasing histamine.
Right.
And that could account again for some of the fluctuations we see in many of the symptoms of long COVID, including loss of sense of smell. So, there are a whole range of over-the-counter anti-inflammatories or prescription anti-inflammatories which don't need to be injected that have potential roles in the treatment, both of long COVID symptoms in general and in COVID-related smell loss.
And when you talk about antihistamines, you're talking about simple over-the-counter antihistamines like Beckinase or something like that. Is that?
Well,
no,
Beckinase is a steroid.
Steroid nasal spray. Excuse me. I should know better by now.
Well, again, we need to do work to see how best to deliver these, what strength we need. So it may be that a simple over-the-counter antihistamine isn't enough, but that's certainly an area that I'm looking at the moment.
Good. Okay. A couple of questions here, which are coming in. What's PRP? Well, PRP is platelet-rich plasma. Is that correct?
So essentially you take a blood sample from your patient, you spin it down to get the platelets and also all of the sort of nutrients in the blood that stimulate recovery. So PRP has typically been used to try and treat tendon injuries, to promote natural tissue repair in that sort of injury. But equally, you can inject it into the olfactory cleft, the area at the top of the nose, to try and stimulate recovery, reduce inflammation, stimulate the stem cells.
Thank you very much. Someone else has asked, what is the anti-inflammatory Claire has just mentioned? Alphalipoic. So is alpha-lipoic acid also an anti-inflammatory?
We think so. So a lot of these things, it's not quite clear what mechanism they might work by. For example, vitamin A drops as well are also thought to have anti-inflammatory effects. So many of these things that are currently undergoing trial probably work, if they work, through that mechanism. So there aren't trials to show the benefits yet of omega-3, alpha-lipoic acid, vitamin A. There's some anecdotal evidence, but it is likely that they are working in an anti-inflammatory mechanism.
Right, because I think that the research on alpha-lipoic acid wasn't, for instance, wasn't robust enough that it was included in the BRS ENT UK consensus study for guidelines on COVID-19.
Yeah, absolutely. And that's one of the challenges with all of these new potential treatments. And, you know, there are many. We've seen dozens of different things coming up in social media posts. In the past, there was very little funding available for smell research, and many trials of treatments involved very small numbers of patients, 10, 15 patients, recruited at different time points after they had lost their sense of smell. And they were studied without a control arm. And so patients, imagine taking 10 patients, giving them a brand new treatment and measuring their sense of smell 3 months later. Now, what we know from patients with post-viral loss prior to COVID and with COVID is that there's quite a good natural spontaneous recovery rate. And so if you take 10 people and do nothing, the chances are that 7 or 8 of them will show some improvement in their smell scores over that time. Therefore, if you take that same 10 people and give them a brand new treatment, you're likely to see improvement in smell scores in 7 or 8 people. Right. And those 7 or 8 people will truly believe that it's because they've been on a treatment. They've got nothing to compare it to. They don't know where they would have been without that treatment. And so if you do an uncontrolled trial, particularly with small numbers, it's very difficult to take out that background natural recovery from any effect of the new treatment that you give. And so what we need to do is do what we call a randomized control trial, where we take a number of patients and give them the active treatment, but we take an equal and similar group of patients starting at the same baseline and give them basically a placebo, a blank treatment, so that we can truly compare the difference. And when you do that trial setting, you might find one of 3 outcomes. You might find that the improvement in both groups is exactly the same. That is, the new treatment is doing nothing and the recovery is just down to the natural improvement alone. And that's a genuine fear for many of these things that we've seen reported, because if we look at the recovery rates reported, it's actually no better than that we're seeing in this cohorts that we're studying just with no treatment at all. There's a chance that the improvement in the study group might be better, and that then gives us confidence that that new treatment is worthwhile and should be recommended to other people. But there's also a risk that the recovery in the group of patients on a new treatment might be worse. And for example, it might be causing increased inflammation. Now, they might still be getting slightly better over time, but not having as much improvement as they would have done if they hadn't had the treatment. Or perhaps in really severe cases, they might actually be getting worse. And a really good example of that was a study using zinc paste in the nose many years ago. You know, there was lots of talk that zinc was a good thing, therefore, the more zinc you put in, likely the better it worked. And when they subjected zinc to a randomized control trial, they actually found out that the outcomes in the group that took zinc were even worse than the group that had nothing. So it's really important to remember when we look at all of these novel treatments being described, potential things, that yes, they might work and they need to be explored in a proper scientific setting with with good outcomes and really sort of careful measurement to see how they do, because there's always a risk that actually even something very seemingly low risk could actually cause harm and actually impair recovery rather than improve it. Right. And that's why I think, you know, sometimes I will post on the Facebook groups just a word of caution, just because, you know, we've got to remember that treatments have a risk of harm as well as potential benefit. And sometimes it, you know, I understand how desperate people are to find new treatments, but they need to understand the limitations of many of the trials that we've had in the past and many of the treatments now that are being promoted without any trials at all.
Right. And that brings the conversation neatly to that there's an extra layer that goes on top of this, which is the kind of amplification that you get, you know, in forums such as the AbScent Facebook groups or within the network, where if, you know, someone comes forward and says, well, what is this stellate ganglion blockade? And, you know, I keep hearing that it's really great. I've seen this on YouTube, etc.
Yeah.
And so I think it's really important for anybody who is, you know, watching these things to be really skeptical and thoughtful about, you know, where does this news come from? You know, what's the basis for it? Somebody posted a link to an article that was written by the people who are in the company that actually makes the product.
I'll come back to stellate ganglion blockade, but if you remember back, sorry, my phone's ringing.
That's all right. We'll get through it. We'll just ignore it.
If you go back to right at the beginning of the pandemic, there were a number of treatments being promoted that just seemed crazy. You know, if you flick the back of your head really hard, your sense of smell will come back. And we can all imagine that that does sound a little crazy and the chances of it working are pretty small. So everyone's quite skeptical about it. But if you take enough people really early on in the course of COVID and flick the back of their head, by chance they will get their sense of smell back within 24 hours because there's that high early recovery. And the people that it doesn't work for will go, you know what, I knew that that was a bit crazy, and they'll never talk about it again, and, you know, they'll just forget about it. But if you're one of those people that by chance happen to get your smell back straight after, that will reinforce your belief that, well, I think this really worked. So you're more likely to go on and promote it on social media and elsewhere. And there's this thing called respondent bias. So if we have a new treatment and, you know, substance P, brand new tablet, if it sounds like it's going to work, particularly if you make tablets red, they're more likely to make you think they're going to work. You really want to believe in it. If somebody posts on Facebook, look, I've tried this new drug. Have you tried it? Did it work? You are much more likely to respond if you've had a positive response. So if you have 100 people and 10 happen to get better on substance P, but 90 didn't, probably only a couple of the group that didn't respond will actually go to the trouble of saying, well, it didn't work for me. But you're much more likely to come onto social media and say, yes, it really worked, you should use it. So this kind of amplifies the suggestion that some things might work better than they do. And that's why it's really difficult to sift through social media polls. Even if there's a vote, you know, did this work for you? It's always going to exaggerate the likely effectiveness of a treatment. So you've just got to be a little bit careful with that. Right. Again, it's great to share potential new treatments, but it doesn't necessarily mean that they're going to be effective for somebody else. And again, you know, not only is there a risk of harm for some of these treatments, but there's also a risk that people are going to spend a lot of money out of pocket trying things that may not work. If we come back to the stellate ganglion blockade, you know, I can't see a way that the mechanism by which stellate ganglion blockade works could possibly help the sense of smell. So, you know, not to say I'm absolutely certain it doesn't, it needs to be properly evaluated, but it blocks part of the autonomic nervous system. The autonomic nervous system regulates things like heart rate, you know, all of our natural bodily functions. So it prepares us to fight or flight, gets your heart rate pumping, gets your blood pressure up, gets you ready to run away from a lion. But there is no evidence that I'm aware of that the autonomic nervous system regulates sense of smell in any way. And so suppressing part of the autonomic nervous system, I can't see a mechanism where that could feed into sense of smell. So it's hard to understand how that might work anyway. If we look at the trial data, there are a number of papers that are being promoted on social media. The data is when we look at studies, we try and look at the quality of the study to see how reliable we find the results may be. There's a whole mixed group of patients in the studies that I've seen. They've got smell loss from all different causes. And actually, when you look at the data, the recovery rates are as we would expect from all of those different causes without any treatment. So very low rates of effectiveness in people with traumatic brain injury, quite good rates of recovery in people with post-viral loss, which again is what we would likely see. So I'm not convinced by the evidence for stellate ganglion blockade. I can't understand a mechanism by the way it might work. I don't want to be too pessimistic, but I think it really, the risk of harm in having something injected into your neck, around major vessels, around the nervous system is certainly there. And I would certainly urge caution, and I think it needs to be properly evaluated in trials. Now, the frustrating thing for that is it takes time, but I would really encourage people to wait until we have that data.
Right. How exactly is it done? So where does the needle go?
Well, in the neck to where you think the stellate ganglion would be. Now it's, I imagine that that's quite difficult to find, and certainly without ultrasound, Doppler and different ways to do it, there's certainly the risk of injecting something into the wrong place.
Interesting. I mean, another thing that people are reporting on social media and on YouTube as well is that SGB is the answer for Porosmia. Now, I've had a look at the papers that, or I should say the papers that I've seen about SGB never mention Porosmia. And I think that for people who are, we all know that Porosmia is just the scourge of olfactory disorders. It makes your life absolutely miserable. It makes it, you can't eat, etc. And so I think people are desperate to hang on to any sort of thin ray of hope. But I fail to see anywhere that anyone has actually demonstrated that Porosmia could be affected by this. That seems to me to fly in the face of everything that we understand about the way Porosmia occurs. But even this nurse in Texas who is giving these injections, who is then widely reported as being a doctor, but he is not, saying, well, of course, it's nothing to do with the olfactory nerve because I'm curing people of their Porosmia with these injections. So I do think that's something that anyone who thinks about the science, etc., would know needs further investigation.
Yeah, and Porosmia is still sort of, we've always talked about loss of sense of smell as being the Cinderella sense. Well, Porosmia and qualitative olfactory dysfunction really is the Cinderella of the whole of olfaction, because all of the focus to date has really been on restoring sense of smell. Now, it's very likely that inherent in that, the Porosmia will shorten in duration as well. We've just submitted 12-month data on Porosmia for a journal for publication. And we found that at 12 months, 1 in 3 people's Porosmia has recovered post-COVID. 2/3 are still suffering. But those that have reached a normal sense of smell, the Porosmia has a shorter duration. So it does seem to fit with our understanding that this is a recovery phase, that it is a positive predictor of long-term outcome, even though it's a horrible phase of going through. And so it does seem to fit with our sort of theory of rewiring and getting the right connections and the whole system working again. So again, when we think about stellate ganglion blockade, I can't see a mechanism by which that could impact on Porosmia. Now, researching Porosmia is even more challenging than researching loss of sense of smell, because for loss of sense of smell, we have very clever tests such as sniffing sticks or AbScent tests that allow us to actually measure the strength of sense of smell, the ability to discriminate between different items over time. But there is no test for Porosmia. It is entirely reliant on self-report. And with every trial, there is always a placebo effect. We want to get better, and we therefore often temporarily feel better after any treatment. So when you're reliant on any self-reported outcome, you always see benefit immediately after the treatment. But if you see the patients further down the line, that placebo effect is often short-lived and they're back to where they started. You know, the mind has an amazing ability to want to make us better. And so the placebo effect isn't us exaggerating things or imagining it. It's a real thing, you know, white coat effect, all kinds of things. But it is likely that any transient improvement in Porosmia is likely to be a placebo effect rather than a true treatment effect. Now, absolutely, we need to measure that in trials, but I suspect that's where there may be some belief that it's helping people.
There's been an interesting comment in the chat bar from Charlotte, who says that another problem with stellate ganglion blockade is that people try new foods that they didn't know they could already eat after they've had the treatment. So they think that it's the SGB, but really it was already, they'd already recovered to that extent. And I think that's a great illustration of how that sort of thing happens.
And that's another thing that's going to be incredibly challenging with Porosmia research, because the triggers change over time. And
Yes.
so you may get improvement in one trigger, but actually another one emerging, and it's very difficult to understand how that fits in a treatment. How do you account that as a success? Is that a bad outcome? So it is very complicated.
And you know, another thing that I see a lot in the forums is that there is a high degree of anxiety that goes along with Porosmia, especially in the beginning, and that this makes the whole experience even worse. Or people will report that they're going through, you know, they were sort of recovered or things were getting a little bit better, and then something really bad happened. You know, they found themselves in a very stressful situation, and then the Porosmia got worse again. So I think there are things that are affecting people's experience of Porosmia that are not entirely clear and are not very easy to measure. So I'm sure that's contributing to the problem.
Absolutely. We see very similar things with tinnitus. Now, tinnitus is an abnormal perception of the noise that the ear makes. So similar in many ways to Porosmia. And we know if you're tired, stressed, or unwell, tinnitus gets worse. The brain is plastic. If it is aware of something, the emotional distress causes amplification of that symptom. And Porosmia is very distressing. And some of the uncertainty around it, the worry if it will ever get better, some of the lack of support from, you know, it's a symptom that's very difficult for friends and family to understand. All of that feeds in and makes it worse. And so any little bit that you can get that relieves stress, tiredness, feeling unwell is likely to help Porosmia. And that's where some treatments such as acupuncture may well come in and be helpful. Anything that relieves the anxiety coming from the Porosmia will help the Porosmia itself.
Yeah, agreed. And I always chime in to that effect when we have discussions about acupuncture, because you know, it can be very very relaxing, very stress relieving for people. Somebody else mentioned foot reflexology, and if it makes you feel better, then it's a good thing.
Yeah, it's with all of these things, we have to weigh up the likely benefits of risk versus harm. So something like foot reflexology, risk of harm is absolutely minimal. The only risk is the cost of getting the treatment done.
Yes.
When it comes to something like stellate ganglion blockade, injecting something into your body, the risk is many steps higher, and therefore we want to be really sure that that's the right thing to do. And certainly for that treatment, I don't feel that we have sufficient evidence to recommend it outside any kind of research setting at the moment.
You know, one of the things that I think is really makes it difficult for people who are in the forums and read the feed to help them kind of navigate all these new, you know, everything that's coming up that's new, what the research is, what's you know, it's difficult for people to be good consumers of new research, or let's say good consumers of what they see on YouTube or TikTok. And I wonder if you could just give people a brief idea of what the timeline is for getting an idea, getting the research together, writing it up, putting it into peer review. I think people very often don't understand what the timeline on that is, and they get very frustrated that they don't see enough evidence of scientific research being conducted. So could you explain that to the listeners and maybe help them understand that a bit more?
Well, I see that very much as a frustration. People feel that nothing is being done, but there are a huge number of studies going on worldwide in this area, many fold more than ever has been done in olfactory loss before. But in order to do a research project, you have to put a proposal together. That takes many months. You have to then apply for funding. These trials are expensive to run, and they involve a lot of people, many centres often. Grant applications often take 12 to 18 months before you get an answer. You then have to recruit patients to a trial, and although there are many people that want to take part in trials, it often takes longer to recruit than you would like. You then have to wait until everybody's completed the trial treatment and then have a team to analyse the results. That has to be written up, submitted to a journal. The journal sends it out to reviewers to say whether they believe in the research and will publish it. And typically, before COVID, that process would take about 5 years, if not longer, from a thought for a new treatment to a trial coming out. And certainly that's how long it took us to undertake the trials for the biologics and to get the data published. They were many years in the making, even with funding and support from pharmaceutical companies. Now, one of the advantages of COVID is that all of those steps have been accelerated, both by increased funding, increased willingness to take part in trials, bigger numbers of patients affected to recruit into trials. A lot of the journals are fast tracking peer review for COVID papers. And we also see some trials being sort of pre-published, the results being made available before they've gone through that benchmarking or that peer review. So the timelines have come down, but it's still taking, probably a period of at least 18 months to 24 months before we'll see a trial treatment coming through into the papers. And so that's why there appears to have been very little research, because even with that accelerated phase, we're only starting to see papers coming out. And just before the webinar, I've looked to see, and there are a number of things in preprint already, for example, that PRP study. So I think in the next few months, we will start to see a flurry of new papers. Now, that's very difficult for doctors to keep on top of, as well as for patients. And so I'm also part of a group called the Cochrane group, where basically somebody is sifting through all the medical literature to identify new studies as they become published. Someone is then really rigorously applying standards to each trial so we can quality assure the trials and rate each trial that's published with a level of certainty and how high we think the risk of bias is. That's, how believable are the results.
And is that published somewhere? Can you go onto the Cochrane website and take a look at what's, how they rate the most recent 10 articles having to do with olfactory loss?
Now, at the moment, it's what we call a live review, so it's been constantly updated, and there are only 2 trials that will be included in the latest iteration, but it will get updated on a very regular basis.
Right.
So that's a really good place to go to see whether, the trials that have been published really stand up to scientific methodology and can be relied on. So Cochrane is publicly accessible. And those reviews looking both at prevention of long-term loss and treatment of long-term loss in COVID will be updated regularly. And obviously we'll feed that back to you at AbScent to share with the members as well.
Can you tell us a little bit about what it means to be on a preprint server? Because I think that when people hear the word published, they think that this is now out there and this is whatever the results are in this paper that's been on a preprint server is now legitimate and can be taken as read. So can you help people understand a bit more about that?
So that's one of the reasons that Cochrane needs to evaluate the quality of papers, because publishing in medical academia has a whole range of different journals, different levels of peer review, different standards. So there are some sort of really key journals, JAMA, Lancet, New England Journal of Medicine. And to get a trial or a study published in there, it has to be absolutely the highest quality, lowest risk of bias. every box has to be ticked, and it's very difficult to publish in those journals. But if a paper is in one of those top journals, we can be pretty confident with the results. At the other end of the spectrum, there are a number of what we call predatory journals that simply will publish anything sent into them if you pay the money. So, you know, there are journals that if you pay them £2,000-3,000 will publish anything that you send to them, no matter how bad it is or how unreliable it is. So even if something is published in a journal, it's still no measure of quality. On top of that, we now also have preprint servers, and they've been around for many years, but were really important in the early stages of COVID because it allowed researchers to share data very quickly before it had gone through any process of peer review. Peer review is, you know, you send a paper to a journal, they will send it out to 3 or 4 experts in that field, and they will rate whether they think the results are robust enough to be published. But you can put something on a preprint server and it becomes widely available before any kind of peer review process. And what we've seen, particularly with COVID papers, is that about half the papers that go to preprint servers actually make it into the published literature. They get past that quality check. But a significant number of papers either get withdrawn or never get past that quality check, but they're still shared widely in the literature. And so that can be a problem. So, you know, many papers on a preprint server are good quality and will end up in high quality journals, but not all of them. So that again makes it really difficult for both doctors and patients to look at new research.
And I think also that these preprint servers, you send your paper to the preprint server, but that preprint server exists as its own entity. And that paper might wind up in this journal or it might wind up in that journal. So it's not as though the preprint is, let's say, preprint for JAMA. It's just out there.
They just take what you send in and they put it on their server and it's available for everyone. Yeah. So, you know, a really important way to share rapidly without the delays of peer review. But many of the things that are on there, you know, simply don't get through peer review because they're not deemed to be reliable and of good quality.
Right. Good. Let's talk a little bit about photomodulation. This is something that people are asking about a lot. For those of you who are listening and don't know what I'm talking about, this is that little device which shines little red lights into your nostrils. So could you tell us a little bit about that and whether or not you think this might be a worthy line of inquiry, or, you know, what do you know about this?
Well, it's not something I have a great deal of experience with. It's been around for a while and has been potentially trialed in the treatment of allergic rhinitis. And again, it links back to perhaps there is a link with inflammation and anti-inflammatory role. In terms of COVID-related smell loss, again, I don't think we've got the evidence. The only thing I've seen is a very small trial, about 10 patients, again, uncontrolled. And the patients were all at very different points in their loss of sense of smell, but the majority of patients in this small study were very early on in the course of their post-COVID loss. So I think 8 out of 10 had smell loss for less than 2 months. And actually, we know at that stage, there's quite a high rate of natural recovery. Mm. Now, they did find some improvement in people with the 2 patients with longer lasting loss as well. But again, we're still seeing natural improvement. So I think, it's one of those things that definitely merits further investigation. The risk of harm is low, but there is a cost associated with it. The mechanism fits more with what we understand, but we simply don't have any control groups to understand whether it's going to accelerate that natural recovery rate or not. So, you know, it's something to keep an eye on. But again, like many of these things, I don't want to sound too negative, but we can't recommend something with any confidence until we've seen a sort of a control group arm to these studies.
Yeah. And of course, that's the problem for AbScent as well, because, you know, we strive to have content feeds that are really clear about what is understood to be useful and beneficial for patients. But we try to steer clear of these things that are unproven, and what we don't want to have happen is for people to think that we are endorsing these things. Naturally, people want to discuss whatever is latest and what they've heard about, which is fine. But you know, we have to be, we at AbScent, we are always very cautious about what we will put into our feed and think about that very carefully. And of course, sometimes people get upset about that because they feel that we are perhaps withholding something that might be helpful to them. And of course, that's never the case. We always want to make sure that we are bringing people, you know, the best and latest information, but some of these things are not necessarily, you know, latest information. So.
And that's the problem, you know, everyone naturally is looking for solutions. And if you found something that you think works, you know, you want to share it as well. And everyone does that really in very good faith and with everyone's best interest. But as I said, we always come back to this challenge that, is it really doing anything more than nothing? And remembering that there's always a potential that these new treatments might actually slow recovery instead of accelerate it. And that's why, you know, we keep going on about the need for a control arm in these studies, for bigger numbers, for proper scientific study with measured outcomes over time, so we can really understand whether things are working.
So believe it or not, we're getting to the end of the hour. So I'd like to take a couple of quick questions here. Somebody has asked, is zinc in tablet form, is that recommended? I think we discussed that a little bit earlier on as being, you know, not necessarily, you know.
So I think with many supplements, I would suggest that a multivitamin and mineral with 100% recommended daily amounts of all of these things, lightly helpful. Make sure your body has all the nutrients it needs to repair itself, but nothing in excess. So I wouldn't take any supplement over and above its natural recommended daily amount. And that applies to B12, you know, vitamin D, and all of these things that you might take. Certainly make sure your body has everything it needs, but don't take extra.
Okay, good advice. Helga asks whether you could tell us a little bit about your understanding of phantosmia in relation to recovery timeline and nerve function.
Well, phantosmia is really difficult to explain. It's less frequent than porosmia, but found in about 30% of people after COVID. Whether it's, you know, or I guess an olfactory hallucination is the right way to describe it, but if it's a memory that's triggered something, whether it's something visual that's triggered it, the sense of smell is really closely related to what we call the limbic system, and it has many memories. So that's one of the things that people say, that they've lost the sense of smell. They find it difficult to build those new memories, but you might just get sight of something that triggers that memory, that brings a smell to mind and causes the phantosmia. So it's likely that that's how that works. We've seen that porosmia is a positive predictor of long-term outcome, but I haven't seen phantosmia come as a positive or negative in terms of treatments, in terms of predictions. There's a treatment called sodium citrate that was trialed for loss of sense of smell and porosmia, and it didn't seem to help either of those two very much, but it did seem to reduce phantosmia. Now, again, it was an uncontrolled trial and hard to know whether it was chance alone, but, you know, that's perhaps suppressing some of the activity in a way, but it's again something that's likely to improve with time, but harder to explain.
Thank you. Now, and here comes a good question, one that comes up often. How effective are MRI and CT scans in offering a clue as to what the anosmia cause or problem is? Are there specialists to examine these scans?
So they are next to useless, I'm afraid. I'm really disappointed when I see people say they've had both a CT and an MRI, and their only value is looking for other potential causes of smell loss. So, for example, a CT scan might pick up polyps, but usually endoscopy will see that. In 2 years, I haven't found anyone that's had COVID and lost their sense of smell who has turned out to have anything else going on. So the chance of picking something else up is so small. I don't recommend imaging at all. MRI, you know, there's questions about, can you see changes in the olfactory bulb? Well, the problem is the olfactory bulb is a variable size, and for the vast majority of people, unless you've got a pre-COVID MRI, you've got nothing to compare to, so you can't see if there's any change. That doesn't tell you about the mechanism. Again, it's simply that there aren't signals going through, so we expect there to be a little bit of shrinkage, and it doesn't predict how you're likely to do in the future. So it really has no value unless anxiety about could this be something else is overwhelming.
More sinister.
Yes.
Yeah.
And are we looking for something more sinister? No. You know, we know that COVID causes loss of smell and Porosmia, and therefore we're not expecting there to be anything else. You know, we're not looking for the small print. And so, I think we can reassure people that there is no need to have an imaging. We're not worried that there's another underlying cause. Scans often pick up incidental things that then themselves cause more anxiety and more harm than good, but it doesn't really have a useful role in post-COVID smell loss.
Right. Another question about steroids here. Are there side effects to taking long-term steroid drops?
So very few. Depends a little bit on the type of steroid drop. So budesonide and beclomethasone drops do have some absorption of the bloodstream, about 40%. So, at a recommended daily dose, they are safe for 6 to 8 weeks. I wouldn't use them for a really prolonged period. If you're going to need something for prolonged periods, there are safer forms such as flixenase, or you can put them in an irrigation and that dilutes them and reduces the amount of absorption. And actually some of the best evidence is for steroid rinses rather than putting the drops in directly.
Yeah. Good. Okay. I think we are going to wind up this evening, and I would just like to remind you that we will be back in a couple of weeks with another webinar with patients. So we'll be just chatting about our experiences. That these patient webinars have been extremely popular, and I do hope you'll join us for that. If you miss, of course, any of our webinars, you could always catch up on YouTube, and we will be also turning the webinars into podcasts so you can catch up when you're on the go. So it's just left for me to say thank you very much, Professor Claire Hopkins, for being our guest tonight. We've really enjoyed hearing about all the latest news, and see you all next time, everyone. And thank you very much for your attention this evening. Good night, everyone.
Thanks, everyone.
Bye-bye.